It is a pleasure to have every one of you on board with us as we have collaborated. The Caribbean College of Family Physicians has collaborated with the Minister of Health and Wellness to bring you a very important topic, screening guidelines for hypertension, cardiovascular disease, and diabetes in Jamaica. The Caribbean College of Family Physicians is a regional college, and it has members in different Caribbean territories. And it is the aim of the college to nurture and train doctors to be care providers, decision makers, communicators, community leaders, and managers. In fact, we would like to have excellence in these areas. So we're going to keep practicing and updating our information so that we can be guided about possible solutions and strategies so we can work with our patients. We join hands with the Ministry of Health because we do not operate in silos. Each one of us plays a very important role in what happens to the health of our citizens in this country. So hand in hand, we hold hands together across virtual reality to make this conference on national screening guidelines a success. We have with us Dr. Julia Rowe-Porter from the Ministry of Health and Wellness, and we also have Dr. Charlotte Badassi, who will open with a word of prayer, blessing the proceedings. We have also three very important presenters who are very expert in their own area of expertise, Drs. Williams Green, Dr. Wilk, and Professor Marvin Reid. So at this time, I invite Dr. Charlotte Badassi to open with a word of prayer. And at this time, Charlotte, you can come. Thank you.
Good afternoon, everyone. Now let us pray. Our Heavenly Father, to you all glory and honor and power and dominion belongs. We come to you today in the name of Jesus. And we thank you, Lord, for this opportunity for us to meet together this afternoon as planned. We recognize you, Father, as the great physician, as the healer, as the wonderful counselor, as the God of power and might, as the God of wisdom, knowledge, and understanding. And we thank you, Lord, for what you have already done, for what you continue to do in our lives, in and through us, to bring hope and peace to others. May your presence be felt among us this afternoon. Cause us to share and receive knowledge, wisdom, and understanding, Lord, to continue to serve others according to your will for us here on earth. I pray, Lord, that your peace and comfort will continue to rest and abide in us and upon us. And help us to remember, Lord, that you are still God, and that with you all things are possible. We thank you, Lord, for what you're going to do among us this afternoon and beyond. And we give you all the praise and the glory, Lord. In Jesus' name we pray. Amen. Amen.
Thank you very much, Dr. Badassi. It is important to have, it's a hymn that stays in my heart. It's called Wonderful Words of Life. That we have these words of life, not just for ourselves, but also for patients and to other persons that we encounter. Especially in these times, because we meet people and we don't even know if we're going to see them again. So I think we want to be really extra kind to people and see how we can help them get along in their own lives, health-wise and otherwise, because we are people first, and also we are medical doctors, and we live in a community, we live in a nation. And as I said, hand in hand, we can do wonderful things together. At this time, I'm going to ask Dr. Julia Rowe-Porter from the Ministry of Health and Wellness to bring greetings.
Dr. Buckland, moderator for this afternoon session, President of the CCFP, Professor Marvin Reid, distinguished presenters and panelists, colleagues, including clinicians from the private and public sector, It is indeed my privilege and pleasure to bring you greetings on behalf of the Ministry of Health and Wellness this afternoon. Apologies for Dr. Nicholas Skyers, our Director for the NCD and Injury Prevention Unit at the Ministry, who had another engagement today. Even though we are on lockdown today, we can't take for granted that you could have been elsewhere. You know, sometimes in the virtual space, the demands for meetings and workshops increases. So you could be elsewhere, or you could be engaged with activities with your families. So we are grateful for the over 400, almost 500 participants that have registered and logged in to join us today as the NCD and Injury Prevention Unit at the Ministry continues our partnership with the Caribbean College of Family Physicians in the dissemination of the National Screening Guidelines for Hypertension, Cardiovascular disease, and Diabetes mellitus. We're all aware that the pervasive pandemic of NCDs has become a significant burden on individuals and their families, our health system, and our society on a whole. NCDs accounts for the top 5 leading causes of death in Jamaica. In 2016, 3 main NCD groups accounted for over 12,000 or 65.7% of all deaths in persons 5 years and older. And cardiovascular disease accounted for 33.7% of this, cancers 19.3%, and diabetes 12.7%. Metabolic risk factors for NCDs are very prevalent and continue to increase in both adults, children, and adolescents. Many Jamaicans are also unaware that they will, that they have an NCD, and they are often diagnosed in the advanced stages of the disease. In addition to that, they are at risk of severe disability, or they often die prematurely from their condition. This was evidenced in findings in the Jamaica Health and Lifestyle Survey, the third one, which was done in 2016-2017, which indicates that 4 out of 10 persons, 40% of persons with raised blood pressure and diabetes are unaware of their condition. 40% of persons that have the condition are walking around with diabetes, hypertension, and they don't know it. Let us let that sink in. That's that has significant implications. Therefore, a key strategy for prevention and control of NCDs is being employed by the Ministry of Health and Wellness. This is the early detection and diagnosis of chronic illnesses. And this strategy has been employed because there is well-established evidence that screening and early detection can reduce premature mortality due to these NCDs. The National Screening Guidelines for Priority NCDs in Primary Care was developed and approved in June 2020, last year. And these guidelines are freely available on the Ministry's website under the resource section, and it's also available on the NCD and Injury Prevention and Control website that was launched this year in July. This interactive training workshop this afternoon is a follow-up session from the series conducted in May 2021, and the session is deemed necessary to further strengthen the capacity of our primary care clinicians in the delivery of patient-centered prevention and screening services for hypertension, cardiovascular disease, and diabetes. We acknowledge that this may be a paradigm shift in a primary care system that often emphasizes treatment and care of ill clients over prevention and screening in well clients for one reason or another. And this session is also strategically scheduled at such a time as this. It is sandwiched between the commemoration of Caribbean Wellness Day or Caribbean Wellness Week, which started September 12, and this commemorative event is a commitment by the CARICOM heads of state, the heads of government of CARICOM, issued at the 2007 Port of Spain Declaration uniting to stop the epidemic of chronic non-communicable disease, and it emphasizes significantly to the development of heart disease, specifically cardiovascular disease. The ministry is committed to our mandate to strengthen the delivery of primary care services for the prevention and control of NCDs through strategic partnerships between the public and private sector. Thank you for your time and support. It is our hope that this session will be of additional benefit, and we look forward to further engagements of this nature in the future. Thank you.
Thank you very much, Dr. O. I know the partnership is very beneficial to all of us, and it's evidenced by the number of persons who are participating this afternoon. At this time, we're going to bring on someone who's known to many of us, Dr. Pauline Williams-Green. She's a family physician in Linstead, St. Catherine, Jamaica, since 1994, a very experienced doctor. She's an adjunct lecturer at the Department of Community Health and Psychiatry, University of the West Indies, and has published on family medicine education and is presently involved in mixed methods research on obesity. A former Caribbean College family physician president for the Jamaican chapter and at the regional level, she is passionate about continuing medical education for family physicians and accreditation of general practices. She comes to us this afternoon to do the first presentation on the Ministry of Health and Wellness's Screening and Assessment Guide 2020, integrating screening in client encounters. Please help me to welcome Dr. Pauline Williams-Green. You can clap where you are.
Life is all this excitement.
It really is.
And if you don't have excitement or unpredicted occurrences, you probably live in a very bored life. And with none of us physicians are living bored lives, are we? So my topic, after the delay in starting, is integrating screening in client encounters. And I thank the Ministry of Health and, of course, my second husband, Caribbean College of Family Physicians, both Jamaica and local and regionally, for this opportunity. And I notice our local president is also on, Dr. Senia Nuju, so it's give her a big shout out. All right, let's proceed. We're going to be talking about integrating screening in your practice. I'm a family physician, primary care practitioner like most of us here. And so that's what we're interested in. Dr. Roe Porter pointed out that we have 40% of our adult population walking around the place, not a clue that they have hypertension or diabetes or cardiovascular problems. So we're into screening. So we'll talk briefly about screening, then about the opportunities that we have when we see our clients, and of course, importantly, what are the systems we should put in place in our practice? So screening, we did talk about this when we discussed the other two topics, hypertension, cardiovascular risk, and diabetes, but it bears repeating. So screening is the application of procedures to populations in order to identify individuals with a probability of being affected by a fatal or disabling condition. This results in the creation of two groups, those with a high probability for the condition and those with a low probability for the same condition. Hence, we end up with a high-risk group and an average risk group. And I think Dr. Hamlin Nelson, who was a chief consultant, explained this well in the guidelines, so have a look at it. So we also have in your guidelines the World Health Organization definition, which is the presumptive identification of unrecognized disease in apparently healthy, asymptomatic population. And we detect this by means of tests, examinations, and other procedures. Let me just get rid of this. Okay. All right, so let's go on. So screening for COVID-19, can't leave out COVID-19 here, eh? So COVID-19 is also being screened for. And when we screen an apparently healthy population. And we choose a method, some test or some procedure. And in our case, we have chosen in our population to use temperature checking. And no need to talk about whether it's sensitive, specific, doesn't matter. It's our procedure for testing, all right? All right, so in terms of screening, we screen the asymptomatic population. We screen it when it's in the latent stage, it's at a very early manifestation, or individuals are unaware of what is happening. The advantage of screening are it certainly delays complication, it's preventative in many cases, and it's certainly more cost effective. And so it fits the adage, a stitch in time saves 9. So I'm quoting my boss now, Professor Marvin Reid. What are the opportunities for screening? Every encounter is an opportunity for screening. And for this, your guideline recommends the life course stage classification to be used. So for our screening opportunities, we look at our individuals as they come to us. The children, we see them age 0 to 9, adolescents 10 to 19, adults 20 to 59, and late adulthood are those 60 and over. And then the special classification is the pregnant and postpartum stage for women. So what are these client encounters? Repeating Professor Marvin Reid, every client encounter is an opportunity for screening. So we look for opportunities when we immunize, school medicals, we're doing a lot of those now, employment medicals, driver's license medicals, checkups, and then we'll talk about how we can use one screening encounter to create other screening opportunities. So a well baby visit, we know the child health and development passport. It's an excellent prompt. Okay, sorry, moved ahead of me. It's an excellent prompt. It has weight charts, height or length charts, and it gives us important questions on feeding, weaning, development milestones, which we can use to determine risk for obesity, risk for hypertension. Then, of course, the school medicals, and these are, oops, running away with me. Sorry about that. School medicals, and we know these, they contain details to determine body mass index. They're also asking us to use charts as well to determine risk for obesity, where the new ones are asking us for waist circumference, blood pressure, urine for glucose and protein as usual, and of course, vision. So again, we can make risks, determine the risk with those. All right. I think it's OneDrive that's conducting my session for me. All right. Last but not last, but driver's license. And of course, persons 75 and over are asked to do insurance medicals in order to drive on our roads. So we need to determine their history, do a review of systems. Of course, again, body mass index, waist circumference, the usual blood pressure, urine analysis, and vision. All of these are being used to help us determine the risk for our cardiovascular problems, diabetes, and hypertension. Here's my favorite. Doc, I need a checkup. And this is another opportunity for us to evaluate our clients for their past medical history, family medical history, social history, review of systems, and of course, determine their BMI as usual, waist circumference, urine analysis, and blood pressure. And of course, you do your usual physical examination. And based on this, we'll be able to develop risk for hypertension and diabetes, as well as other cardiovascular problems. So, what are the systems that we have in place in our health centers, in our primary care practices to ensure that we do the screening? Well, I can tell you about mine. We do body mass index at regular intervals, usually at every visit or at least once per year. Blood pressures are done at every visit. Urine tests for protein and glucose, as well as blood glucose for diabetics or those who request it, or just upon the patient's request. But that's specific, ad hoc, and very incidental. We need, importantly, to have proper systems in place in order to do regular screening. And therefore, I commend to you system strategies. And these are patient and physician screening reminders. Similar to the passport that the child has, which has reminders for us, we need to put in place these reminders. Of course, we need our ministry and our regions to give us performance report of screening rates. That will help to motivate us as well as to help direct us as to how well and what changes we need to make in our screening. I can't emphasize too much the use of an electronic medical record. It's so much easier to be tracking the persons being screened, as well as follow-ups needed electronically rather than going through this manually. It's very difficult and tedious, but can be done. Of course, the implementation of in-practice guidelines based upon training, as we're doing now. You look at your guidelines and you use it as a means to keep you on the straight and narrow path, using the charts that are in these guidelines, which will help you to know how to act, when to intervene, which groups are in the high risk, which groups are in the low risk. All right. And of course, use of nurse practitioners and other healthcare practitioners to facilitate these systems. And I'll talk a little bit more about the facilitators in this next slide, which is trying to move. We haven't gotten there. We're still at opportunistic, but trying to move from opportunistic screening to universal screening, which is the idea. For this, we need leadership from our ministries of health. We need leadership at the regional level and at the parish level. And we need to be ready. Training today is a form of the readiness, but we need to be ready not only for physicians, but everybody in the health team, that screening is a priority. Communication and feedback. How well are we doing? What are the barriers? What are the facilitators that will help us achieve screening for all our population? And then I referred to it earlier, the screening champion in each practice. Often this will not be the physician. It will be your nurse, your public health nurse, your CHA, community health aide, who is charged with putting into practice all the activities and tasks necessary to screen as many persons as possible. Certainly to inform clients and patients that they need to have screening depending on where they are in their life cycle. And of course, public health campaigns, which will lead or help our patients to come in out of their woods and nooks and crannies to ask for screening, as is happening in some cases with prostate cancer. So we need the practice facilitators also. These are distinct from your screening champion in your practice. These are consultants who can look from outside and tell us help us overcome the barriers, help to facilitate the things that work, help us with our electronic medical record. These are persons that are trained, usually public health persons, who will help us to stick to the task at hand of screening. And of course, the methods must be cost effective in order to be sustainable. So thank you for your patience and understanding and the challenges we had in this meeting. The definition of screening we did, the client opportunities, and the system strategies were looked at. Thank you very much.
Right, thank you. That was excellent, Pauline. Thank you very much. I liked the interaction between you and Sam as you were actually working out an issue, and it shows you how we actually can also work with our patients, because they can come up with their own solution. We have to work along with the patient. We're not dictating to them, but we're actually guiding them and having that conversation to guide them along. All right, so excellent, really wonderful presentation. Thank you so much. Our next presenter is Dr. Rohan Jerome Osei Wilkes, and he's going to be presenting on Ministry of Health and Wellness Screening and Assessment Guideline 2020, Cardiovascular Risk Assessment in Clinical Practice. Dr. Rohan Wilkes is a consultant cardiologist, a Jamaican, and he got his Bachelor's of Basic Medical Sciences from the University of the West Indies in 2003, Bachelor's of Medicine, Bachelor of Surgery 2006 from the same university, and then his Doctor of Medicine in Internal Medicine in 2013, also from the University of the West Indies, Mona. Additionally, he completed a fellowship in clinical cardiology at the University of Toronto in 2016. Currently, he works as a consultant physician in cardiology at the Kingston Public Hospital, consultant cardiologist at the Winchester Cardiology Services, and consultant cardiologist at the Heart Foundation of Jamaica. He's an associate lecturer in the Department of Medicine at the University of the West Indies, and an executive member of the Association of Consultant Physicians of Jamaica. So you see, we have a very experienced and knowledgeable person in the form of Dr. Rohan Wilkes, who is here to present on the Ministry of Health and Wellness Screening and Assessment Guideline 2020, Cardiovascular Risk Assessment in Clinical Practice. Dr. Rohan Wilkes, your turn to drive.
Good day. I'm Rohan Wilkes, a cardiologist and member of the Association of Consultant Physicians of Jamaica. And we're happy to partner with the Ministry of Health and Wellness on this program. Today we'll be talking about cardiovascular risk assessment as part of the program review of the National Non-Communicable Disease Program. Today we want to talk a little about the burden of non-communicable diseases, outline the importance of screening, talk about what target groups need to be screened, where do we want to screen them, and we're going to discuss a few clinical cases to illustrate the screening process. We know that non-communicable diseases account for the top 5 causes of mortality in Jamaica. Cardiovascular disease, cancer, and diabetes account for 2/3 of the deaths in Jamaica. Hypertension is the main modifiable risk factor for cardiovascular disease, and 60% of Jamaicans greater than 15 years of age have hypertension. So it's extremely important for us to look out for this risk factor, detect it early, and treat it. Cardiovascular disease is the world's #1 killer. We know this includes hypertension, which is the main modifiable risk factor for atherosclerotic cardiovascular diseases, which includes coronary artery disease, and stroke. What we want to do, we want to prevent people from developing atherosclerotic cardiovascular disease and having cardiovascular events. How do we do this? With prevention. So we have to look at all the risk factors in these patients. We need to look at their diet. We need to look at their physical inactivity. We need to look at their exposure to smoke, whether it be first-hand smoking, second-hand smoke, as well as the importance of air pollution. We need to detect kidney disease early in these patients, and we need to look at their BMI. We know that obesity is a huge problem in our population, and we need to look at these factors of diet and exercise and how to get people to their adequate weight to prevent hypertension, prevent diabetes, so that patients don't end up in the hospital with heart attack and strokes. And that starts in primary care, in the health centers and in the communities. 40% of people with hypertension and diabetes do not know that they have these conditions. So this highlights the importance of screening. Finding people even in the absence of symptoms, evaluating them, and finding these illnesses so we can treat them early and prevent cardiovascular disease down the road. The target groups we want to focus on are divided into children from 0 to 9 years of age, adolescents from age 10 to 19 years, adults from 20 to 59 years, adults in late adulthood. These are individuals who are 60 years and older, and a specific focus on pregnant women and women in the postpartum period. The settings that we want to see screening happening are in 3 main settings: in the community, in level 1 centers, and in level 2 centers. As it relates to the community, this can be in a myriad of places: in the household, in various institutions such as the church and the school, and in community organizations such as youth clubs and sports clubs. We know that our level 1 health centers include community health centers and the district health centers, and the level 2 includes our comprehensive health centers, and we want the screening program to be rolled out in all of these health centers. Some key items that we need to focus on equipping our health centers with are appropriate blood pressure monitors with appropriate cuff sizes, appropriate for all ages. We need to have scales and stadiometers, because as we will see, calculating our body mass index for our patients is of utmost importance. Urine dipsticks to assess for proteinuria, and we need to have reliable laboratory services so we can get our investigations back in a timely fashion in order to evaluate our patients fully. Here we have displayed the variety of cuff sizes that are appropriate to have in our health centers so that we can measure blood pressure effectively. Now we'll move on to some of our cases. Our first case is quite a common scenario. A young man of 12 years old who has chronic asthma, who presents to the health center for routine follow-up for his asthma. As we focus on attacking the non-communicable disease program, we don't want an individual like this to go by the wayside undetected. So even though he's here for asthma, we have to pay attention to his cardiovascular risk, even at a young age of 12. So someone like this should have their height and weight checked, so we can know their BMI. So in this scenario, this is a 12-year-old boy, comes for asthma, but we see that his BMI is 26 kilograms per meter square, which at that age is consistent with obesity. We also do his blood pressure, even though again, he's just here for asthma, and we notice that his blood pressure is elevated at 136/90. As should be done in all settings, when the initial blood pressure is elevated, this should be repeated twice. We see where subsequent blood pressures are 130/90 and 132/85. So we have consistently elevated blood pressure in this young man. So what we have here is a high-risk adolescent boy who is obese and has elevated blood pressure. So someone like him, we need to take action. He needs to have a full medical with a focus on his past medical history, key focus on family history of any cardiovascular events, especially myocardial infarctions and strokes in first-degree relatives at an early age. And he needs to have a full physical examination, including an eye examination to look out for any hypertensive retinopathy. He needs to be investigated with a complete blood count, renal function, urinary protein, and electrocardiogram. And someone like this who is at high risk should be referred to internal medicine for further evaluation and management. Here we have displayed the algorithm which is designed to guide us in assessing the risk in adolescents. We see where these are people who are asymptomatic of any cardiovascular disease. And one of our first steps is to measure the blood pressure and do a cardiovascular risk assessment. As we said before, if the blood pressure is elevated, we repeat it twice. And once confirmed, we move on to a full medical profile and referral to the specialist as necessary. If our initial assessment is negative, we want to make sure that we plan for annual evaluation in our more high-risk individuals, such as somebody who is obese or has a strong family history of cardiovascular disease. But if they're average risk, they can be evaluated every 2 years. In our second case, we have a 45-year-old female who comes to you in the health center complaining of epigastric discomfort. Now, she comes to the office complaining of this discomfort, which she attributes to gas. But in your evaluation, you notice that she has an elevated BMI of 32 kilograms per meter square, putting her in the obese range. So you want to dig further. Is this really a gastric complaint, or are we missing a cardiovascular disease here? So we need to tease out the history further to determine what we're looking at. You want to ask specifically about the triggering factors for this epigastric discomfort. Is this epigastric discomfort related to exertion? Is there any associated shortness of breath? Does she get diaphoretic? And you also want to look more at her risk factors. Is there any history of cigarette smoking history? Does she have a brother or sister who has had a heart attack or stroke? Did any of her parents die at an early age for unknown reasons? Did they have a heart attack or stroke? All these are key in determining what this lady's risk is. Along with that, with her being obese, we want to evaluate for other risk factors. Does she have dyslipidemia? We need to do a lipid profile to find this out. She's obese, she's at risk of diabetes. We have to detect if she has diabetes. So we can treat her diabetes if she has it and prevent her from developing cardiovascular disease. The physical examination is very important. We want to look for evidence of cardiomegaly. We want to examine her lower limbs, assess her pulses. Is there any evidence of peripheral arterial disease? Are there any trophic changes in her skins or nails pointing towards this? All of these are important in our assessment of her risk so we can know how to manage her adequately. So here we have our cardiovascular risk chart, and this is the chart that we should employ for all our patients. For this lady in particular, we look at the chart, we see that it's divided into different sections. On the left, it applies to men, and on the right applies to women. And within the section for the women, we have a section for non-smokers and for smokers. And we can see how the risk varies with these different categories. So for this lady in her 40s, who is a non-smoker, and her blood pressure, her systolic blood pressure is below 120, we see where she still falls in the low risk range. So even though she's obese, her 10-year cardiovascular risk score is still less than 5%. And so she would not require any further treatment, but she will definitely need ongoing lifestyle adjustment and assessment of her lipids and blood glucose. On this slide, we show that her total cholesterol is 5.6 and 4.5. So now that we have this additional information, we can plug in her values into the laboratory cardiovascular risk assessment chart. So you will notice that in addition to having age and blood pressure, at the lower portion of the chart, there's also total cholesterol values, which adds to the assessment of the cardiovascular risk. And again, this lady remains in the low risk category, so she'll need annual follow-up and aggressive lifestyle. Here we have the algorithm applying to adults. We see that in the, if the blood pressure is elevated, this person is in the high risk group. They will need a full medical profile, and if their risk is high, referral to the specialist. If their risk assessment is low, this person can be reviewed annually with ongoing risk assessment. Our third case looks at a pregnant female. This lady is 32 years old. She's gravid at 2, para 1, currently at 24 weeks gestation. Of importance is that she has a previous history of preeclampsia in her previous pregnancy. In addition to that, her blood pressure is elevated at 150/100. Luckily, her urine dipstick is normal with no proteinuria. However, because of her history of preeclampsia and her current elevated blood pressure, this lady is deemed high risk. So we should move quickly to assess her investigation in terms of her blood count, her renal function, lipid profile, and blood glucose, along with an electrocardiogram. And this lady certainly should be referred to the high-risk clinic for closer follow-up. Again, we have the algorithm here. To the top, we see where we see when the person has an elevated blood pressure. Again, repeated to confirm that it is indeed elevated. And once that is confirmed, then a full medical profile is done, and they're referred to the high-risk antenatal clinic. If the blood pressure is normal, this person can just be seen more frequently in the regular antenatal clinic without referral to the high-risk clinic. In our fourth case, we have a 62-year-old gentleman that presents to the clinic complaining of poor erections. This is a key case highlighting the importance of cardiovascular disease. We know that impotence has a close relationship with cardiovascular disease. So when a man comes with a complaint such as this should go off as a red flag and tell us that we need to dig further. We need to ask about his cigarette smoking history. We need to ask about his activity level. Is this gentleman sedentary, or if he's very active? If he's sedentary, is he sedentary because he's having symptoms on exertion? Because we know that patients adjust their lifestyle to symptoms, which can mask the symptoms sometimes. So again, we need to dig deeper. We need to ask about chest discomfort with exertion, shortness of breath on exertion. We need to be on the lookout for heart failure in a gentleman like this. Is he having shortness of breath on lying down? Is he waking up breathless? Is he developing ankle edema, suggestive of heart failure? As we examine him, we make note of his blood pressure, his pulse. We know that atrial fibrillation is a big risk factor for stroke in the elderly. Is the pulse regular, or is it irregular, consistent with atrial fibrillation? We need to look at his BMI. Is he overweight? Is he obese? Does he need to be referred to the dietitian to achieve his target heart rate? Again, examination of peripheral pulses is important to look for peripheral arterial disease. Elderly gentlemen like this also can develop aortic aneurysms, so the abdominal examination is extremely important in trying to detect that. Once we've finished with our clinical evaluation, we order the appropriate investigations, looking at his cholesterol levels, his LDL and HDL, check for his blood glucose, and check for protein in his urine as a sign of early kidney disease. He needs an electrocardiogram. He definitely needs to be counseled on lifestyle change, specifically for smoke cessation, diet and exercise to achieve his target weight. He needs to be counseled on his cardiovascular risk, because he is at greater than 20% risk of having a myocardial infarction or stroke within the next 10 years. And because of his blood pressure elevation and his high cardiovascular risk, he definitely needs to be started on pharmacotherapy for his hypertension. And again, we have displayed here the algorithm for a person in late adulthood, where once we detect high-risk features and they have elevated blood pressure, they should be referred to specialists for further management. If not, again, they can be reevaluated on an annual basis to assess their cardiovascular risk every year. So to close, we want to touch on some key points. We want to remind you that we need to look at the patients in the context of their target group. We want to use our history, our examination to assign them to the average risk group and the high risk group to treat them appropriately. Where appropriate, we want to do a full history, a full examination to touch on key points looking for evidence of cardiovascular disease or looking for risk of cardiovascular disease. I want to use our cardiovascular risk charts as a tool to quantify this risk. As you see on the risk chart, it puts patients into low risk categories, moderate risk category, high risk, and severely high risk categories. And we use this information to communicate to our patients what is their risk of ending up in hospital with a heart attack? What is their risk of ending up in hospital with a stroke? What is their risk of ending up with heart failure? Because it is important for them to know how their actions today can impact their mortality or even their morbidity. Because everyone wants a good quality of life. And when a patient knows that they can improve their quality of life by adhering to adjusting their risk factors, adhering to their medications, adhering to their clinic visits, it can make a world of a difference. So utilize this information, empower your patients so that we can reduce the burden of cardiovascular disease.
Thank you very much, Dr. Rohan Wilkes. That was an excellent presentation. All right, so we'll hold the question and answer sessions for the end. So the next presenter is Professor Marvin Reid, and he's going to speak to us on the Ministry of Health and Wellness's Screening and Assessment Guideline 2020, Case Discussion and Practice. Now, who is Professor Marvin Reid? I think all of us should know Professor Marvin Reid. And if you don't, I will let you know a little bit about him. This gentleman, he does a lot of things. He is in academics, he's in clinical practice, he is in voluntary work, not just in Jamaica, not just in the region, but for the entire world. Professor Marvin Reid is a past director of the Tropical Metabolism Research Unit, Caribbean Institute for Health Research, and associate lecturer in the Department of Community Medicine and Psychiatry at the University of the West Indies, Mona. His research interest spans the gamut of community medicine, clinical trials, and human metabolism. He has co-authored over 140 peer-reviewed articles and has received the Mona Campus's Principals and UWI Vice Chancellor's Award for Research Excellence, as well as other international awards for research publications. Professor Reid practices as a family physician in a group practice and is a member of the Family Medicine Specialty Board at the University of the West Indies, which advises on postgraduate family medicine training. He is a member of several national, regional, and international professional bodies, such as the World Organization of National Colleges and Academies, we call that WONCA, Medical Association of Jamaica, American Physiological Society, as well as a member of the Research Advisory Committee of Caribbean Public Health Agency, CARPHA. He is the current president of WONCA North America and the Caribbean College of Family Physicians. It is indeed my pleasure to invite Professor Marvin Reid to take the driving seat and present to us on the Ministry of Health and Wellness Screening and Assessment Guideline 2020, Case Discussion and Practice. Professor Marvin Reid, over to you.
Hi, thank you, Chair. I was just wondering, though, whether or not it may not be better for us to just take some questions for Dr. Wilkes, because he's on call at KPH, and we know sometimes, even though he's here now, he may have to attend to an emergency. So I just wondering if it would be better for us to just take some questions for him, since we have him.
Thank you so much for that recommendation. Yes. Anybody who has questions, you put it in, you can just put it into we have a question and answer section on this? Yes, we do. Let me see.
So I think the first question would be, the usual screening tests are easy and cheap. How do you diagnose your OSA patients when suspected? Since sleep study is expensive and OSA adds complications to HTN, DM, and arrhythmias. Arrhythmias, apologies. Dr. Wilkes, I'm not sure.
Good afternoon, everybody.
Hey,
Oh,
afternoon.
yeah, man, I'm here. I've been hearing you. Thank you for that question. Well, thanks again to the Ministry of Health for involving the ACPJ in this project and asking me to do this presentation. And thanks to the CCFP as well for having me to respond to some questions. Well, yes, obstructive sleep apnea, extremely important condition because of its impact on non-communicable diseases, as stated in the question. You really need a sleep study to diagnose it. As you know, there's really no workaround. You can suspect it clinically based on symptoms of snoring, daytime somnolence, etc. But you really need a sleep study to confirm the diagnosis. So it really is one of the many areas in our healthcare system where we need improved access because it is indeed expensive, but it's important to recognize it, suspect it, diagnose it, and treat it, because it really does have an impact on hypertension and arrhythmias, etc.
Okay, thank you very much. There's another question. How do we get the cardiovascular assessment form?
I think those are available through the Ministry of Health. Maybe one of the representatives, such as Dr. Reporter, could respond to that better. I know they've been, she's putting it in the chat now, but I know they've been rolling it out in the health centers. And it looks like there's a link there that we can access them, that Dr. Reporter just put in the chat.
Right. Let's see. Can you see my chart here? What I did?
Let me.
Can you see?
Oh yes, it's laminated.
Right. So I downloaded it and laminated it because I'm using them with my patients, and I'd ask I think it's apart from us doing the risk assessment, I think it's very important that we actually have the patient work on the risk assessment chart with us. What is lovely is that it is really color coded. So we can ask them if they're a man or a woman, and that, of course, they're going to laugh, you know. And then we can ask them if they smoke or don't. And then so we know, and if they're, but it depends on which one we're doing. If we're doing the non-lab based chart or the lab based chart. But it's on the WHO website, WHO Cardiovascular Disease Risk Charts, and you can get it from there. Print it off. I would suggest that you laminate it because it's going to be a very good tool that will get our patients focused. Because sometimes when they're in with us, we need to get them talking back to themselves. So are they a man? Are they a woman? Do they smoke? Do they not smoke? Find out how old they are. And then we find, remember Dr. Wilkes had said, okay, well, for the category. So if they are, say, in the 50 to 54 year group, we can look at that category. And then also then, at that time, check their systolic blood pressure. So they feel you're pumping up the blood pressure and they say, okay, the top reading is the systolic blood pressure. That is a very important reading. And then so they can get that value. And of course, you take them across to do their weight and their height. So they can get their weight and height checks, and you calculate their BMI together. Don't do it by yourself, do it with the patient, because they're going to be so curious what you're up about. And then you show them and you let them read out the numbers, and then you can show them if they're in the green, the yellow, the orange, or the red. When they see exactly where they are, that's where they are right now. And then you can ask them, okay, what can we do differently? Well, you can't change your sex. That's debatable, but you know, you're really not changing your sex. But that, of course, that is going to break some ice to them, you know. And then you can't change your age either. But the more at risk you are, it means that, especially when you get into the darker colors, it means that your heart age can be really higher than your own physical age. So if I am, say, 50, and then I get a very high risk number, that is going to clue you in that your heart age is older than your physical age. So it could say that your heart age is 75. And that is the reason why some people actually drop out. You say, why did the person drop out and they're so young? Because their heart and their blood vessels were older than their age. And then they can say, okay, so how are we going to actually fix this? What can you do differently? So there are only two things, really. Three things on the chart here is either they're smoking or not smoking. Okay, they don't smoke, or they smoke, we just deal with that. And then, okay, how can we lower the blood pressure? And if they are overweight, you can indicate, well, if you lose between 5 to 10% of your body weight, you may actually bring down your blood pressure. If you have a 5-liter bottle of alcohol or water in your office, do let them feel that, because that is weighing about 7.5 pounds. And if they've put on 7.5 pounds or anywhere between that from their last visit to you, time they saw you, you make them feel that and you say, okay, this is the amount of weight you put on. And when they lift it with one hand and said, wow. And I said, you know, the body is really a super packer because it's wrapping this around your body and it's pressing down on your blood vessels and making your pressure go up. So you got to unpack it. You want to actually know, tell me how you're going to unpack it. We can get help for you. But you need them to think about it, all right? See what their solutions are, what they're going to do differently. But it's a good chart to actually download and laminate. It's nicely color-coded, but use this. Let the patients work with you. You don't work out their risk only. Let them look at it so that they can realize that there is something wrong. I remember a doctor had asked me, did this person realize that he had a heart problem? It was a diabetic person who had died. And it was very important. So we may have talked about one so and so, but you know, I kept wondering, how can I answer that question? Because it is, did the patient understand that he had a heart problem? And I think this is where we need to move, getting the patients and finding out, do you understand? I remember I had this 83-year-old lady in my office just Saturday, and she was coming in, and I asked her, and I asked her, do you, among the things, do you smoke? She says yes. And then we did different checks, and I said, do you realize you have a problem, heart problem? She said, what? I said, yes, you have a heart problem. And I said, if you continue smoking, the next cigarette could actually put you under 6 feet. So we had to get talking on that because it was a big shock to her, learning this at 83. And she only smokes 5, but even 5, one is far too much. And this lady is very interested in her health. Otherwise, she wouldn't have come all the way from St. Thomas to Kingston. So it's just a matter of having that conversation with the patients. But the chart is very useful. And Dr. Wills, thank you so much for your discussion and about the chart. The charts are very, very good. There are other questions.
You're welcome, Dr. Buckland.
What is the role of major depression and why not include in the screening and treatment? I think we have, okay, I'll let you answer.
Yes, so depression is extremely important. It has a very close relationship with cardiovascular disease. Patients with depression are at higher risk of cardiovascular disease, and people with cardiovascular disease can develop depression as a result. I believe the Ministry of Health and Wellness has separate screening guidelines for depression. So this presented today was just focused on cardiovascular disease, but there are separate depression screening guidelines.
Right.
I just want, could I chime in here as well? Yes, you're correct, Dr. Wills. Thanks for that. So the screening guidelines prioritizes 7 chronic conditions: diabetes, hypertension and cardiovascular disease, depression, and 4 top priority cancers: breast, cervix, colorectal, and prostate. This presentation today, and especially Dr. Williams Green's presentation, emphasized holistic screening and approach. A patient that comes to you with a female or male adult that comes to you that is being assessed, they will have routine screening for each of those conditions that are due at a particular time. Of course, they would need to get depression screening based on the guidelines outlined in the manual. So it's important to remember that even though we are focusing, Dr. Wilkes' presentation focused on cardiovascular assessment, in the practice setting, we would of course do depression screening and pap smears for the women and diaries and PSA testing for the men. And we are looking forward to continuing to work with our mental health team to roll out the depression screening element of our approach to screening. And we really look forward to working with them. But we're doing it in a modular fashion. So we're doing hypertension, cardiovascular disease today, as well as diabetes, and then we'll move on to the other conditions later.
Okay, thank you so much. So doctor, thanks you very much for the presentation. I would like to know what is the best strategy for a teenager who seems overweight and at risk for diabetes? Also, what recommendations for challenges with losing weight despite monitoring caloric intake and exercise?
Okay, thanks for that question. Well, even as you said in the presentation, even a teenager should have a proper risk assessment done. And then based on their risk category, then you treat them accordingly. Well, there's really no good workaround lifestyle modification. Well, I will say we have to remember to employ the services and expertise of our nutritionists and dietitians. I know sometimes there is some reluctance from patients to seek help, and then there are issues with accessing them. But I think that's an important tool to use in our armamentarium in helping patients to achieve adequate lifestyle modification to get their weight down when overweight and reduce cardiovascular risk.
Right, it's a team approach, and we actually need to rope in the family, because a kid lives with a family, and get the family in so we can really talk about the whole risk of the entire family, because the kid is just a symptom of the family, right? What characteristics of the pulse that would indicate MI?
Okay, that question is a little bit out of the scope of this talk. There are no pulse findings that are specific to a myocardial infarction. It really can be, but if they're in cardiogenic shock, then it can be low volume pulse.
Okay, and how reliable are digital blood pressure? How reliable is the digital blood pressure kit?
That's a good question. Well, I find reliability varies. We know that the blood pressure kits that measure the blood pressure using the upper arm tend to be more accurate than those at the wrist. There's also some variation dependent on brands. I find a good strategy is if someone has a digital blood pressure kit, to ask them to bring it into office and check it, back to back with their machine along with your your known reliable machine, and see if the readings are congruent. And usually when that's the case, then you know that their home readings can be reliable. And if there's any added doubt, I find ambulatory blood pressure monitoring is a good tool to use to confirm good blood pressure control.
Thank you. Dr. Sloper, welcome for being here with us. She'd asked, could you expand on the use of sleep apps with recordings to diagnose sleep apnea, especially those that link to a Bluetooth oximeter, for example, Sleep for Android app?
Okay. Yeah, I'm not sure if any of them are approved. There are limitations with sleep studies that are not monitored. The gold standard is to have a monitored sleep study, an overnight setting where all the parameters can be measured in terms of EEG, ECG, pulse oximeter, etc., so that the diagnosis can be accurate. There is a role for home sleep and monitored devices when the pre-test probability is significantly high, but the gold standard is to have a monitored sleep study in an appropriate center rather than a home study or using apps.
Yeah, Professor Reid would like to actually also add something to that. Professor Reid?
Not at this time.
Oh, I saw something that you wanted to say. All right. In light of COVID-19 and the perpetual lockdowns, physical activity has almost become obsolete. What recommendations are being offered for exercise regimens in the home? Prior to COVID-19, the Minister of Health advocated wellness for physical activity. I just dance. Just put on something and just dance. Anyway, you're over to you. The question is addressed to you.
Well, yeah, COVID has impacted us in many ways, including this. It's hard for me to speak on behalf of the ministry. I do know that even though the focus has been taken away from the Jamaica Moves project because of COVID, I do see they still have the programs on television daily, the exercise programs encouraging people to exercise. But certainly it's difficult. Not all of us have space in the home to exercise if we aren't able to go to the gym or out to the field. It's difficult. But I think people should still continue to, get physical activity where they can. And even though we have lockdowns, I think on movement days, if you go to an open field and you're not close to other people, I think you can exercise safely.
Yes.
Could I add to that quickly? Since
Yes.
the ministry has been implicated, Recently, just last week, we launched our physical activity website. The ministry is very much prioritizing physical activity, especially now more than ever. I'll try to put the link in the chat. There's also our non-communicable disease and injury prevention and control website that has resources for physical activity. So you can use it to guide your patients, give recommendations to your patients for simple things that can be done in a low resource setting, as well as things that can be done in the workplace. So I'll see if I can share those resources, but it is definitely, physical activity is still a priority of the Ministry of Health and Wellness.
Okay, another question. Screening will have to be automated. In the UK, general practices and hospital clinics, one takes one's blood pressure before going in to see the doctor or the nurse. Are we sticking to the old way where a single doctor and a patient paradigm?
While Dr. Wilkes looks at that, I don't know, I'd like to come in, may I?
Yes, please.
Yes, I really read a couple of pieces of literature about the things or factors which would facilitate screening in our primary care setting. And granted, they were mostly from the USA, and they definitely emphasize the use of facilitators, screening champion in your office or your health center, the use of automated systems, whether there be a partial electronic medical record or some kind of automation, because you just can't go through dockets and dockets. You can, but it's challenging. Okay, the host wants me to start my video, so here I am. So really and truly, I know what I do in my practice, but it's dependent on my memory. And I have the chart, just as you do, Dr. Buckland, from the ministry. But how do I get all the practitioners in my office to do the same? You need usually not a physician. You need somebody else who will be a champion, who will say, Doc, this person, put a little note before the person even comes into your office. And then this person follows up. Did you do your mammogram? Did you do whatever? And for Dr. Earl Wright, puts that depression chart, those 2 questions, the PHQ2, in the docket as well, whatever. But a system must be in place, and lower level persons are better at keeping the system going. Physicians need only support it and help to implement. Sorry, Dr. Wills, I just have a thing about that, so you can go now.
Okay, no problem, Dr. Williams. Yeah, I just wanted to get back to Dr. Sloper's question. Sorry, I just had to read it over to understand it properly. And it's an important point because, you know, there is even data to show that you can eliminate white coat hypertension if you check the blood pressure with an automated machine rather than when the patient comes in the office and they're there with the doctor checking the blood pressure. So if the resources are there for you to have an automated machine in a separate treatment room before the patient goes into the doctor, it saves on the contact time. So you can see more patients and screen quickly, and you can eliminate some incidents of white coat hypertension.
Right. Does marijuana smoking increase the risk for cardiovascular disease? And if so, how?
Well, I don't know of marijuana increasing the risk of cardiovascular disease. There's actually some data, definitely some data where they looked at marijuana use in patients with heart failure, and the patients who use marijuana actually had some improved outcomes with their heart failure. But you know, the data on marijuana and cardiovascular disease is relatively limited, but I don't know if it increases the risk of cardiovascular disease.
Dr. Elliott, I think the person meant screening of depression as a CV risk factor We know it is one, so why is it not part of the CV screening protocol?
All right, again, maybe Dr. Roporto wants to jump in on that. I know it's based on the World Health Organization model. And I know, even though we know that depression is important in cardiovascular disease, I know one of the goals of the screening tool is to try and balance its simplicity with its effectiveness. And like other people have been saying, it is time consuming to do the screening. The more things are added, the longer the screening takes. But maybe it is something that the NCD committee can look at in terms of an adjustment to the screening tool.
Okay. Do persons with rheumatoid arthritis have cardiovascular disease?
Well, I think Dr. Roporto wanted to add something to,
Go ahead.
to that response.
Just to endorse what you said, Dr. Wilkes. So the presentation that was done was this cardiovascular risk assessment chart, and they use the main elements that contribute to cardiovascular disease. So BMI, you know, and all the factors, the smoking status, blood pressure, sex. Those are top priorities. But cardiovascular risk assessment is not just confined to looking at those parameters, because you'd have seen where Dr. Wilkes went through the entire history and the entire physical exam. So as a clinician, you must look at the whole person, and that does include their mental health and status. So there's no limit to cardiovascular risk assessment in terms of just what's on the charts. You know, there is a significant clinical aspect, and there is in the appendix section of the guidelines, it gives some guidance as to what to look for in terms of, you know, when you have that consultation with a patient, and it does entail, you know, other elements of the assessment.
Right, so here, thank you. Do persons with rheumatoid arthritis have cardiovascular disease? I think it's a risk factor, you know.
Yes, yeah, rheumatoid arthritis and other connective tissue disease that cause systemic inflammation are risk factors for cardiovascular disease, yes.
Can you say what signs in the cardiovascular system would make you think COVID when in your office outside of pulse oximeter? I'm seeing several COVID positive patients with tachycardia. Yeah.
Right, yes, a lot of patients with COVID will have tachycardia as a response to the fever and acute illness. Again, it's not a specific sign for COVID, so we should evaluate them, you know, with the usual, looking for the usual clinical features.
Mm-hmm. What kind of diet or meal plan would you recommend for an obese client who wants to lose weight? They're going to the dietitian, nutritionist.
Yes.
I think I'll cover that when I do my presentation.
Okay.
You know, we don't work in silos, you know, we have a team, all right? So Rome wasn't built up by one person. So smoking ganja, cigar, and so on are risk factors once it involves smoke as a pollutant. That's right, because it's air pollution. Good point, Dr. Elliott. I think that's the list. Well done. Thank you so much for all the questions. And Dr. Wills, thank you for staying on to answer all of these very important questions and clarifying situations. Also to Dr. Julia Roporter for us, and Dr. Williams-Green for adding value to the discussion, and Professor Reid as well. Well, Professor Reid, thank you. Professor Reid, I invite you to come into the driver's seat and present on Ministry of Health and Wellness Screening and Assessment Guideline 2020, case discussion and practice.
Thank you, Aldith. I'm going to briefly turn on my camera so most people recognize that it's not a robot talking to them. But then after which I'm going to close just to preserve bandwidth, and hopefully things will smoothly. So as I take up the baton, my main aim in this presentation is really threefold. One is to reinforce some of the concepts that were already introduced by both Dr. Wilkes as well as Dr. Williams-Green. The second is really to get all of us as physicians, healthcare providers, whether it be nurses, physiotherapists, pharmacists, to be familiar with the tools, some of which were mentioned in some of the earlier presentations. So to get some hands-on familiarity with the tool. And lastly, I will touch a bit on what it is that we do when it is that we find individuals for whom we have screened, we have assessed, and we have determined that these individuals are at high risk for ultimate outcomes, whether it be cardiovascular outcomes. What are some of the strategies that we can put in place to try and help these individuals? So we're going to be speaking a lot on health promotion and how we can try and do some of that. In doing that, I will also introduce to the group some of the resources and that the Ministry of Health is working on and has worked on to try and assist us in our encounters with our patients. So I will move on by just, as I said, we will be doing a bit of refresher as well as reinforcement. So my first two slides really speaks to why is it that we go about making this decision to screen. I will spend probably a third of my time reviewing the tools for screening, in particular hypertension and cardiovascular disease and diabetes to a lesser extent. And I'm going to be doing, interspersed with all of this, a few practice, the ability for us to practice and engage with the tools. So as Dr. Williams-Green made the point, really and truly, you should have a health problem for which early intervention will improve the outcome, and which the time interval between the risk factor and overt disease is sufficiently long that you can intervene and have a modifiable outcome. For screening itself, and many of us oftentimes tend to confuse screening with assessment. They're actually two distinct processes. Screening is the ideal screening tool should be simple, reliable, and affordable. There are some what we call psychometric properties of these tests, meaning they should be sensitive and specific, and they should be acceptable to the persons who you're going to apply it, as well as the person who's doing the application. The important thing of screening, though, is that the system or the health system should have a way of dealing with individuals who are screened positive. And therefore, we should ensure that we have treatment that are effective, sustainable, and in which the benefits far outweigh the risk. Dr. Williams-Green introduced the concept and idea of opportunistic screening. That is screening that happens occasionally, by the way, you just have an opportunity, versus where we're trying to go at this point, which is to input a universal screening system. So you make it a part of the system. So these lectures that we have been having since May, and they're going to be ongoing for the next, oh, God knows how long, is really to help equip us as healthcare providers to embed it in our DNA, embed it in the way in which we do business, so that it becomes a part of the process that we use in engaging our patients. And so the first sets of lectures or the first sets of discussions by Dr. Williams-Green was really just to lay that foundation for us of how can we look at the screening and try and embed it to make it more universal. Dr. Wills highlighted some of the tools that we're going to need for screening, and I'm only going to be focusing today on the last two. So the Ministry of Health has a screening guideline manual, and this manual is being disseminated as I speak to all the health centers. And of course, it will also be disseminated to doctors who operate in primary care in the private system. Within that guidelines, you will have all the tools that were, within that manual, sorry, you will have all the tools that were mentioned earlier by Dr. Ron Wells. And I'm going to be focusing, as I said, on looking at the World Health Organization Body Mass Index for Age Anthropometric chart. I'm going to spend some time with that. And Aldis demonstrated to some extent the cardiovascular risk prediction chart, as well as Dr. Wilson. I'm going to be spending some time and also giving you an opportunity to be familiar with these particular tools as well. So starting first with the BMI for age, how do we go about assessing BMI in children? So to do that, we just need to take a step back and go back to some of our earlier lectures and ask ourselves, what are anthropometric assessments? And really what these are the use of growth standard, and I'm going to explain what's the difference between a standard, or reference to assess the growth or nutritional status of an individual. Growth standard basically refers to a series of measurements or chart that represent what we call optimal growth. So that if you had adequate money, you were free of infections, you had adequate resources, how would you grow? And between the 0 to 5 years of age, the World Health Organization has created such a chart from a study that was called the Multicenter Growth Reference Study, in which they sampled individuals or children growing in what was perceived to be an optimal environment and health conditions in 6 countries: Brazil, Ghana, India, Oman, Norway, and the USA. And from this experiment, or from this study, we created what we call these growth standards, which represent what would be the ideal growth between 0 and 5. A growth reference really is just a distribution that we use for comparisons. And many of these comes from cross-sectional survey. And the World Health Organization, one that we currently use as part of our toolkit, comes from the growth reference between 5 to 19 years of age, which is really a reanalysis or reconstruction of the 1977 national US growth data. So those are the two bits of standards that we currently have to use to assess. You will often hear when we talk about assessing growth of children and teens, the concept of Z-scores, the concept of percentiles. And so one may ask, what are they and what's the difference between them? And how do we actually use these things to assess growth in children? And so a Z-score really is a standardized unit which represents the number or magnitude of the standard deviation units that a particular value is away from the mean. And it is derived by, this is a formula that is at the top of my slide, that you will see at the top of my slide. So I'll just highlight it here, where you calculate your dead Z-score by taking the measurement that you have, subtracting the mean, and divided by the standard deviation. So what you'll find is that if you take a distribution that is normally distributed, then the mean for normally distributed curve would have a Z-score of 0. And then to the right and to the left, you can see how many standard deviation units you are from the mean. And that's really what your Z-score is. How many standard deviation units are you away from the mean? All right, come on, right. Now, when we talk about percentile, what we're really talking about is the percentage of a score in a frequency distribution that are equal or lower than it. So when we say that we're talking about the 95th percentile, what we're saying is that there are 95% of the population who would have a value less than this particular value. And there's a relationship between your percentile and your Z-score if you're talking about a normal distribution. So on this chart here, for example, again, I've reconstructed it. So 0 is the mean. 1 sigma just represents 1 standard deviation. So sigma is a unit or a symbol often used for standard deviation from the Greek alphabet. And as you can see, between 0 and 1 sigma, you have 34.1% of the population who would have values there. And so if it is that we take, for example, the percentile value that corresponds to 1 sigma, we will actually work out about the 84th percentile, because what that would be is to add the the percentages that are to the left of that particular value. So Z-scores and percentiles are easily interchangeable. It's just that most times on the research side, we often tend to prefer to use Z-scores. Oftentimes when clinicians are discussing growth parameters with patients, they tend to have a better comfort zone using percentiles, but they're easily interchangeable once the distribution is normally distributed. An important feature of Z-scores are that they are comparable across age, sex, and anthropometric measures. So what we mean by that, a Z-score of -2 tells you roughly, so let's say you're doing that for BMI for age, represents a same kind of a description for Z-score of -2 for say a height for age chart, meaning that you're 2 standard deviations from the mean on both of those charts. So Z-scores are useful measures that we like to use. And certainly for the Ministry of Health guidelines, Z-scores is what we have opted to standardize on and not percentiles. So how do we go about calculating now the BMI for age in our children that we see? Well, first we have to measure their weight and their height. And this presentation, I will not go through the technicalities of how that is done. We then calculate the body mass index or BMI. And then we use some tool to convert that calculated BMI to compute or get a BMI for age Z-score. Broadly speaking, there are roughly 3 such tools that you can do. You can do a BMI for age widget, which is available on a few websites, and I'm going to discuss that. You can do the World Health Organization Anthro calculator, and I'm going to demonstrate that. And in the manual that you will receive, you will see that you will get a BMI for age chart, and we will also discuss that. So if you're going to be doing a calculator, then the formula for calculating BMI is, of course, your weight divided by your height, weight in kilograms divided by your height in meters squared. Or if you're still using imperial measurements, it would be your weight in pounds divided by your height in inches squared multiplied by 703. Suppose you wish to use one of these BMI for age widgets. So first thing first, let me caution you is that in trying to translate the numbers and the interpretation of those numbers to the Jamaican context, you must remember that the Ministry of Health has taken a strategic decision that we will standardize using the World Health Organization growth chart or the reference chart. And therefore, you have to be very careful that the widget that you're using actually uses the World Health Organization chart at its back end to do the calculation. The other thing that I must also caution you is that the Ministry of Health has also decided that we want to standardize on using the Z-score as their output and not percentile. And many of these widgets actually use percentile. So although there is the conversion, you need to be aware of them because in the percentile, they often use 95th percentile. But the categories that the World Health Organization uses Z-scores, and we use a Z-score of more than 2 to denote obesity. And that really corresponds to a percentile number of 97% and not 95. So you have to be careful of that. And when I did a search over the last week or so, I actually did not find any ideal or suitable widget that would make sense. The closest I came to would have been, okay, let me just turn off this. Take that off. Right, here. All right, so I'm going to just move another thing over to my screen here. Make it. So the BMI site net, they have a BMI calculator. Again, they use the World Health Organization backend to do the calculations. But the issue here is that their output is really not the output that we would wish because their output is actually in the percentile range and not the output, and not in Z-scores. So whilst it may be useful to give you some idea of what the actual BMI is, certainly in terms of for interpretation, the interpretation would have to be translated to what it is that we currently use, which is the World Health Organization cut points. So the next way to do it is using the World Health Organization software, which is designed for Windows PC. So those of us who use Chromebooks or Macs, we would have to get some virtualization in order for that to do. It has 3 modules in there. It has an anthropometric calculator, it has an individual assessment, and it has the ability to do survey. For the purposes of screening and what we do, what the Ministry of Health has standardized on, the best version, there are 2 of them. One is called Anthro, which is for 0 to 5 years of age. And the other one is called Anthro Plus. And that one is for between 5 to 19. But it actually does cover 0 to 19 for BMI for age. So we can actually use it for the BMI for age calculation that we're doing. And so here I've just shown you the website where you could actually go and download it. You can download the manual. And because it is also need the .NET platform, if your computer doesn't have that, it also provides a tool for you to be able to do that. So that's just to let you know how that looks. And so what does it look like? So I'm just going to give you a quick look through. So this is it on my screen here. So as you can see, it has 3 modules: anthropometric calculator, individual assessment, and the nutritional survey. When you click anthropometric assessment, which is the assessment that we actually use for an individual client, you just need to be able to input the relevant data, whether it's a male or female, what the current weight is in kilograms, what the current height is in centimeters, what the date of birth here. And so if you click on the date of birth, it gives you a drop-down menu. And if you click on the month up top, you can actually choose the month relatively easily, and you can scroll the years also relatively easier. So if we take an arbitrary person who was born in January the 13th, so let's take the January the 19th, and let's put in some weights here. Let's say that this person, we see that this person today is 8 years. Let's say that this person is weighing 40 kilograms and has a height of 130 centimeters. We will then come up to the point where we can actually get what is the BMI for age for this individual. And the BMI for age for this individual is coming out at a Z-score of 2.58. If you click on the chart, it actually plots a chart for you, and it points that this individual is at a Z-score of over 2 or 2.58. And oftentimes I do this and print the chart and give it to the parent and the child so they can actually see where they are. If you want to follow them up individually, the software does allow you to do what we call individual assessments. And this is to facilitate longitudinal assessment of the child. But for a simple cross-sectional visit, the anthropometric calculator is all that you would need. So that's really what that looks like, and that's what the output for that looks like. Colleagues, in order to practice using the BMI for age charts, you'd be we're now going to be looking at the BMI for age in chart and try and get some practice in actually how that is done. So there is something that's slightly out of sequence. So let me just address that for me quickly. That should not be there yet. Right. Right, So that was slightly out of sequence, so we're back in sequence now. So essentially, what we have here is that we have, for example, here, the typical example of a BMI for age for boys. This is a chart that you'll actually see in the manual. And so one of the first things that you're required to do is to make sure that you choose the right chart. So you choose the appropriate one, the appropriate sex-specific chart, whether you're dealing with a boy, or the pink one would be for the girls. So let us say, for this particular exercise, we want to plot a male teen who is age 15 years with a BMI of 24 kilograms per meter squared. The next part is to find the age, which is going to be on the horizontal axis. So in this particular case, we will find the age here, which represents 15 years. And then we will plot the BMI value, which is on the vertical axis. And we can see that 24 would be about here. We will then find the point of intersection between the 15 years and the 24. And that point of intersection is going to be right at this point here, at that red dot. And we recognize that this clearly puts this child or this teen in the overweight category. So we would tend to do the same if we were actually doing a female. And the purpose of this is really just to say what it is for a female. So now we are going to just demonstrate in order to practice using actually get a feel for how you could actually do this. So in order to do this, I'm going to be putting a link in the chat, which you will click on. And with that link, you would then be able to practice a bit on it. I will give you this video is just really just to give you a brief description of what it is that what it looks like. So listen up.
Colleagues, in order to practice using the BMI for age charts, you'll be directed to Survey Any Place. That's a platform.
Right, so that platform is where you will go, there are about 5 or 6 questions. I've just put it in the chat there. There were 5 or 6 questions which you will do as a quiz. And what will happen is that you would, it's
that we'll be using for this demonstration. On entering the platform, that is when you click the link, you'll get a screen that asks for your email. The purpose of that really is just to validate the users. So I'll just type in an email here. Then after that screen, you will then tick next, and you'll get the first set of questions. On some devices, the chart may look a little small. So in order to magnify the chart, what you would do is look for this plus magnifying icon to the top right-hand part of the screen. And if you click that, it will actually
just magnify the charts for you, and then you'll be able to see. If you have a touchscreen device, you can magnify it again with your fingers to be even wider. So I'm just going to give you about 3 or 4 minutes to just go ahead and complete that bit of exercise. All right, so the first question asked, what is the BMI Z-score for Arlene, who is 9 years old with a BMI of 16 kilograms per meter squared? So if Arlene is 9 years old with a BMI of 16 kilogram per meter squared, 9 years old corresponds to this point on the x-axis. And if she's 16 kilograms, that intersects on the green line here. The green line corresponds to individuals who have a Z-score of 0. So we can recognize that Arlene has a Z-score of 0. So what is the BMI Z-score for Arlene? It would be 0. So let's move along. So how would we classify Arlene? Well, we know based on the classification system that we have been instructed to use is that if your Z-score is more than 2, you're considered to be overweight. If your Z-score is over 3, obese, and certain between -2 and 1, you'll be considered to be normal. So since Arlene's Z-score falls in that category, we would consider her to be normal. So we get that answer from the chart. So the chart actually tells you that. So here are the boundaries. So the green is the median, all right, or where normal is. If you are between 1 and -2, you're considered to be normal. If you're between 1 and 2, you're considered to be overweight. And if your Z-score is over 2, you're considered to be obese. So Arlene sits clearly and firmly in the normal range. And therefore we can take normal for Arlene. So just using this as the nutritional component and using the Ministry of Health screening guideline, what would be the risk classification for Arlene? Would she be average risk? Would she be high risk? Would she be moderate risk? Or we don't know. Well, she would be average risk. The reason being that the Ministry of Health has decided to make our life easy in practice. And they really only speaks about 2 levels of risk, average and high. And so once it is that you're normal, you're considered to be average. If you're overweight and obese, then you're considered to be high. All right, so we now move to our next example. And this mother is curious to know what range of BMI would be considered normal for her son, considering that her son is 12 years old. Can the chart help us in answering that question? Well, let's see. So he's a boy, so we've chosen the blue chart, and he's 12 years of age. So if he's 12 years of age, as we discussed prior, the normal range would start from -2 all the way up to +1 for his Z-scores. -2 for 12 corresponds to roughly 14.5, 14.5. And the 1 corresponds to 17.5. What, no, is it? No, 20, sorry. 1 corresponds to 20. So what we're looking for is B, 14.5 to 20. The next example we have is Michael, who was found to have a BMI of 26 kilogram per meter squared. What would be his risk classification? Well, again, we find BMI for Michael. He's age 12, we know that, and he's 26. So if we find 26 there, we find that it is in the obese range. And therefore, based on the Ministry of Health guideline, he is going to have high risk. Ministry of Health doesn't have a moderate risk, either average risk or high risk. And that would complete my thing. So now let's see what I got. Yes, so I got that correct. Yes, I got that correct. So Arlene BMI score of 0 makes her normal or healthy weight. The Ministry of Health only defines 2 categories of risk. These are average and high. With a normal BMI for age, it is likely that Arlene would be an average risk. The other thing that we'll take into consideration for the cardiovascular risk or blood pressure and so on, but just from the nutritional status perspective, she would be average. I've already gone through this, so you could see that it is 14.5 to 20. and Michael is high risk. So we have completed our assignment, and for those of you who all scored 100, you did well. All right, so back to the Zoom platform now. You all did pretty well on that particular survey. So now let's move on to the rest of the stuff that we needed to spend some time getting our heads around. I did spoke to you about it at length, and that is your cardiovascular risk chart. So we see it here. So a few quick things, a few quick notes. So the World Health Organization designed this chart to be used globally. So they had to take into consideration what are some of the resource constraints that countries may have. And so they tried to make these charts relatively simple. We recognize that there are many, many factors that contribute to cardiovascular risk. Mental health factors, body composition factors, laboratory factors, genetic factors, and so on. But what we did was that we looked at the factors that contributed the greatest to those risks, because they're the ones that are more likely to identify the vast majority of persons. We recognize we're going to miss some, but no screening tool is perfect. Remember, we spoke about psychometric properties of tests. They are sensitive and specific. So there are going to be some limitations. So the non-laboratory chart is really for us to work in scenarios where we may not have access to a lab, but we can be able to do a height and a weight, and the person can give us some information as to whether they're smoking or not, and they can give us some reliable information on their age. And once you're going to be using this chart, what you're going to be doing from the Ministry of Health's perspective is to break down individual into one of two categories. The chart has 4 categories. For the purposes of how we propose to work in Jamaica, we only interested in 2. If you're green, you're on average risk. Anything that's above green, anything that's not green, it is high risk. All right? So life is relatively very simple for us. Green, you're good to go in terms of average risk. Anything that's not green, you are going to be at a high risk. So in going through this chart, and I'm going to use my laser pointer here now. First thing first is to find out what's the gender or sex, biologically sex, so it's men and women. Then you want to know what is current smoking status, and we're thinking about current smoking status, not whether they used to smoke and stop, but whether or not they're currently smoking at the point of interviewing with you for this assessment. So if they're not smoking, then they're non-smoker. If they're smokers, still smoking, then they're smokers for the purpose of this risk. We need your systolic pressure, and of course, they need to be over 40. This chart cannot be used or should not be used in individuals who are below 40. Once we have identified that, the next thing that we really want to be able to do is that on the vertical axis on the left-hand side of the chart is the age blocks. So everything on the lower end here represents an age block of between 40 to 44. This block represents 45 to 49. This block represents 50 to 54. This block represents 55 to 59. This block represents 60 to 64. Each cell does not represent an increment in age. You may be tempted to think it represents an increment in age. It doesn't. Anybody who is between 60 to 64 belongs in this block, okay? On your far right, you have the systolic blood pressure categories. So the lowest rung in any block represents those individuals who have systolic less than 120. The next higher row represents individuals who have systolic between 120 and 139. The middle row represents those who have systolic pressure between 140 and 159. The fourth row represents 160 to 179, and so on. So in order to be able to classify an individual, let us say we're going to be doing a male who is a non-smoker and belongs to the 50 to 54 block. It means that we're thinking about this block, okay? If that person's blood pressure is 130, then he's in this row, okay? So The only other thing that would have to determine what is the precise intersection now for us to know what his cell is its BMI. So on the horizontal axis, you have his BMI categories. So the first column represents BMI less than 20, second column 20 to 24, third column 25 to 29, fourth column 30 to 35, and the fifth column 35. So getting back to our gentleman, if it is that we're thinking that he is between, let's say, 52, and he has a blood pressure of 130, we know he's in this row. And if his BMI is 30, he represents here. So he would be a yellow cell. Yellow cell means high risk. If his BMI was 20 to 24, he would be a green cell, and green cell means average risk. All right? So that's essentially what we do when it is that we're talking about using this in a scenario where you really don't have lab facilities. You may not have a point of care to do cholesterol or sugar, and you want to get some idea of what the cardiovascular risk is, right? This is all you really need to move forward. Now, let's assume that you have some labs. Let's assume you have a point of care device that can give you total cholesterol. Again, you can use, and the person doesn't have diabetes by history, or from blood glucose measurements that you may have at your disposal. Again, the principle of how we use it is the same. If you're in the green cell, you're average risk. Anything that is not green, from our perspective, how we wish to deploy these charts in the field is that you're considered to be high risk. All right? Now, the difference between this chart and the previous chart is that for the lab-based chart, we no longer use BMI. We use total cholesterol values because that is a stronger predictor than the BMI. And so if you have access to that, on the horizontal axis, you have the total cholesterol values. Starting in the first column, less than 4 millimoles per liter, all the way up to greater than 7 millimoles per liter. And again, the principle of using it, remember the age just represents the block that we look at. The non-smoking and smoking also represents the block. So once it is that we have identified the gender, your smoking status, and your age, we have identified which block we're talking to. And to find a specific cell in that block, we look at your total cholesterol value, which is on the horizontal axis, and which row you're on based on your systolic blood pressure. All right? So hopefully that is clear in terms of how we actually use the chart. And this is the same thing now. If it is that we know that we're dealing with somebody who is a diabetic, because we have had previous information to allow us to make that ascertainment. Again, as I said, if you're green, you're considered to be average risk. Anything that is not green, you're considered to be high risk. All right? So I'm going to try and give you some opportunities now of practicing on this. So I'm going to put this in the chat like what I did the last time. This is to everyone, to host and panelists. Here it goes. There. All right, colleagues. Same principle as when you did the BMI for a chart. If the screen is too small, just magnify it. If you have a touch device, you can magnify it even more. All right. Again, I'll give you 3 to 5 minutes to complete. All right, great. So thank you all for participating. Again, the idea here is to really just to get all of us familiar with at least the tool, even from a theoretical construct. Clearly, it's like riding a bicycle. The more you actually use this in your day-to-day, the better you'll become at it. The quiz, the scores are not that important for the purposes of this exercise. What is more important is that you get a chance or some practical experience with the tool. So let me start by just going through the questions of the quiz. The goal of screening for non-communicable disease is and Pauline would have addressed this in her original talk, and it's all of the above, right? We want to reduce the burden of non-communicable disease in Jamaica. We want to reduce premature mortality. And we want to be able to use the guidelines that the Ministry of Health has so ably constructed for us to assist us in terms of early detection, referral, and follow-up, right? So all of the above. Congratulations. And then this is a tool. As I said, I know that there may be a bit of a challenge with some individuals on the screen, but let's see if we can work it through. So in this particular instance, let me just look back at the question. We want to know, Mark is 54, he's a non-smoker, he has a systolic pressure of 128, and he has a BMI of 27, all right? So let's see if we can plot all of that for him, all right? He's 54, so we know he's going to be in this slot down here. He has a BMI of 28, so we know he is going to be in the third column, all right? So he's 54 in the third column. And his systolic blood pressure for us, let's just go back here, his systolic blood pressure for us is 128, all right? So his systolic blood pressure is 128. So we know he is here, he's a non-smoker, he's a man, so this is where he belongs in this column. And if his systolic blood pressure is 128, he's in the second row. So with a BMI of 28, he is here, right at this point. All right, so, sorry, right at this point, I'm sorry. The third column. So essentially, he is in a green cell. So if he's in a green cell, based on the Ministry of Health guideline, he is average. All right, we're now faced with somebody who, again, this time is a female, and she's 65 years of age. She's a smoker, all right? And we found that her systolic blood pressure was 136 and her BMI was 28. How would we classify her? So let's go. So she's 65, is a female, so we know we're over on this side, okay? She is 65 years of age. So 65 years of age means that she's going to be in this block because she's a smoker block, all right? So anything that we're going to be doing is going to be in this block, okay? We know the systolic blood pressure is 136. So we know it's going to be this row, all right? And we know that the BMI is 28. So we know the BMI is the third column here. So forgive me if I'm colorblind, but this looks like some form of brown to me. I don't know what people might want to say, but the long and short is that it is not green, so that we know that she is high risk. All right, so let's go and high. The next gentleman that we have is a 42-year-old man, we're told. He's a non-smoker, right? So he has diabetes, so we're going to have to use a diabetes chart. We have a systolic blood pressure of 118 and a total cholesterol of 5, all right? So let's see if we can find this young man on this chart. So the first thing first is that we're looking for people with diabetes. So you see that this is the diabetes chart. It's stated up there, okay? We know he's 42 years of age, and we know that he's a non-smoker and a male. So that means he's in this block, all right? In this particular specific block, right? 42, non-smoker, he must be within here. We know his cholesterol numbers is 5, so we know he's in the third column. And we know that his systolic blood pressure is 118, so he's at the first row. So he's green. And remember what we said, anything that is green is average, okay? We now come to Sharon. Sharon, we're told, is 42. She's a non-smoker, but she has diabetes. So when you need the diabetes chart, the systolic blood pressure here is 130 and the total cholesterol here is 5.2. So how are we going to find Sharon now? So Sharon is 42 years of age. So again, in this this first set of block. It's a female, right? And it's a non-smoker. So she belongs to this particular block that we speak here. We know that the systolic blood pressure is 130. So the systolic blood pressure is in the second row. And the cholesterol number is 5.2, which means here. So again, that's green. And green means average risk. So we click average there again. We're now at Christine, who is 54, right? A female, non-smoker, systolic blood pressure 118, and total cholesterol 3.9. All right. So again, this person has diabetes, so we have to make sure we have the diabetes chart. Yes, we have the diabetes chart. We know that she's 54, so she's going to be somewhere around this side. Non-smoker, so that puts her here. And 3.9 is the cholesterol, so it means it's the first column, which is over here. And she has a systolic blood pressure of 118, which puts her here. So she's right at this little intersection. Again, she's green, and so therefore, again, she's average risk. And then we're moving right along. We're at Paul, who is 54. He's a smoker. He doesn't have diabetes, so we're going to use the one without diabetes. Systolic blood pressure is 140. Total cholesterol is 5. What would Paul be? Again, we find 54, which is in this block. He's a smoker, so that means he's over on this side. His systolic blood pressure is 140, so he is in this third row here, and his cholesterol is 5, which means that he's here. So that he's in a yellow zone, and that means that he's high risk. And that completes our charts. And we should be good, right? As we said, we should be pretty good. And anybody who has my answers would have had a very good score. All right, so congratulations to you all, those of us who were able to finish. Certainly, what I saw was that we had 355 persons attempting this. All right, so congratulations, I'll give you a hand. So moving along now, let me take off the pointer. Yes, so let's keep it on for the time being. All right, so Pauline spoke a lot about incorporating screening into our workflow opportunities. Dr. Wilkes hinted at this too. So any opportunity that we have, we can screen, whether it be the community, in office, or as part of curative visits. And what we need to recognize is that the screening activity doesn't have to necessarily be done by the physician. It can be done by trained healthcare providers. We can use our community health aides if we're in the health center. We can use practical nurses if we're in the private sector. We can use real nurses. Or we can, as Pauline mentioned, get a champion, a screening champion, whose job it is to try and improve our outcome. And purpose, once it is that we have screened, at the end of it, what you will identify is individuals who are at risk and who are not at risk. Individuals who are at risk clearly will have to be seen by the physician, who will then complete their assessment and care. But irrespective of whether or not they're at risk or not at risk, everybody benefits from health promotion and some rescreening interval, some rescreen at a specified interval. So that's a broad conceptual framework. I'm going to quickly just run through a few additional scenarios here, just to reinforce some of the stuff that Dr. Wilkes did. So here, for example, we have a team. This is not something that we're regularly accustomed to doing in our practice, doing blood pressures for children, but we're encouraging all of you to get the appropriate size cuff. And the ministry has committed, the regions have committed to ensure that the health centers will be properly, have the proper tools to be able to do this. And in the manual, it will have the blood pressure cutoff for the respective age. So you don't have to swat it, you don't have to worry about it. It's there. You can do like what Aldis does and laminate them if you want to, but it is there. And in this particular case, from our last example, 101, 58, age 3 years, we see that the threshold here for male is 101.58. So in this particular case, what are we going to be doing? Well, clearly he's at the threshold, and therefore he would definitely need to be rescreened, have his blood pressure taken, and he goes into the high screening algorithm. And so in the document as well, we have a workflow chart which will really tell us and guide us as to what it is that we would need to do for Nakeem. So clearly his blood pressure puts him at a bit of a risk. We'll repeat it twice. And if it is below that 100, then we'll rescreen him every 2 years. If it's still positive, and he has all of this historical component, when we take the history, then he becomes high risk. And then he would need a full evaluation at a proper center, whether it means in the public system or in the private system. He needs to be evaluated fully if he's positive for any of these risk factors that we just mentioned there. All right. So in looking at these charts, the first thing that you really should look at is really to determine is from a history perspective, because we're going to be asking them questions, if they belong to the high risk category, and then look at the measurements that we're going to be taking. For cardiovascular risk, preeclampsia is relatively very common, very high in the Jamaican setting. And we do need to pay attention to our pregnant women. We know maternal mortality is one of the figures that the World Health Organization looks at to judge the health care in a country. So we do pay particular attention to our high-risk women. This particular case, Angela, she does have a lot of high-risk things. She's an elderly woman. She has history of preeclampsia, and she has a BMI, which puts her in the obese category. So she's definitely high risk. Again, if you look at the historical component on this side, which defines who our high-risk individuals are, previous adverse maternal outcome, obesity, which she's satisfied, advanced maternal age, African descent, it means that she's high risk. And so once her blood pressure comes in the high risk value, which is in this case 140/90, she would need to have a full assessment done in a high risk clinic. All right. So that's essentially where we go there. Typical exam, a scenario again, medical. If he's 50, his father died of a heart attack at the same age, so it means early cardiovascular death. His blood pressure is 130/85. What is your approach? Again, if you look at the algorithm, it defines for you who are high risk and who are average risk. All right. So in this particular case, Michael would have been in the high risk category because of his family history. And his blood pressure is above 120/80. So he goes on the top part of our algorithm where he's fully assessed and have a full treatment protocol meted out to him. When we look at the elderly, again, that is again part of the assessment process. Remember, the goal is to try and do this through the life course. So once it is that we have somebody, every encounter is an opportunity to screen. We see he's a smoker, his BMI is normal, his blood pressure is 128/83. Where would you put poor Clifford? Again, he would, in this case, he's a smoker, so that increases his risk. So in a case of this case, even though his blood pressure is over 120/80, that puts him in the high risk category. And again, he would follow the high risk guidelines, which would require him to have a full assessment being done. So that's just a few big cases. So we spoke a lot on hypertension, and cardiovascular risk. Diabetes, we know, is also a risk factor for cardiovascular diseases, but there are specific advice or algorithm given there for screening for diabetes. The main important thing is that what are the tools we're going to have is going to be our history, a lot of attention on the nutritional status. And of course, for diabetes, we have specific screening tests, which is to do your fasting blood sugar, your oral glucose tolerance test with a 75-gram glucose, or if you're pregnant, you can do the Sullivan test, which is the 50 gram of glucose. And here I'll give you what the threshold or cut values are for the diagnosis of diabetes. And again, what we have done, similar to what we have done for the cardiovascular disease, is that in the manual, we have an appropriate set of algorithms which would help guide us. And I'm just going to show these just for completeness sake. For time is going, I'm not going to spend too much time on them. But the long and short of it is that we do give you some instructions as to how it is that you can move once it is that you are considered to be above average risk, which is your high risk. What are the things you're to do? So you'll get high risk because of the historical information we collect. We do your fasting blood sugar and your OGT. If you're positive, you need a full medical profile, all right? And this occurs whether you're pregnant. In pregnancy, we think screening should start at 24 weeks and repeat at 28 weeks. And again, you start with the screening with a Sullivan, and then you move on for the full diagnosis with an OGT, all right? So that's it for the pregnancy guidelines. I just wanted to mention that the Ministry of Health has been working hard in the background. I'm not employed by them, I don't work for them, but they're working hard in the background. And one of the things that they've been doing is creating some additional bit of resources that would allow us, oh mouse, can't behave yourself, that would allow us to help our patients. So let me just go back here. I just wanted to take this off, right? Nope, it's not off. Okay, it's off now. All right, it's not working the way I want it, but such is life. So this website that you see there is, and I'm just going to bring it across the screen, right here. Fortunately, I had a backup. All right. So the Ministry of Health Non-Communicable Disease and Injury Prevention and Control website. They've recently launched this. Julia spoke to you about it. It's a very, very useful set of websites. So on it, if you click down here, it gives the idea about how it is that you can live well. And if you click on that, you will see really some of the basic tips that you can do, how you can be physically active, how you can avoid excess alcohol. It speaks to what we're talking about here, which is the NCD screening. What are the key factors to be concerned about when we talk about NCD screening? So again, the history, what are the things to look forward for? Although we're focused today on hypertension, cardiovascular disease, and diabetes, it covers, as Julia mentioned, 4 cancers: breast cancer, cervical cancer, colon cancer, and prostate cancer. And it also covers depression. And I recalled as well that someone mentioned about the physical activity component. There is a section here on physical activity component. It gives you an idea to ask it to complete the physical activity readiness questionnaires to see whether or not the person can or is in a position to start physical activity. And then there are other sites which really can help you. These sites can help you, give you some ideas of what sort of physical activities you can do. The one thing I want to mention though is the BMI calculator that is on this. The BMI calculator that is on this, it has the BMI widget that is on this thing is only for adults, all right? So I'm going to encourage them to actually put the BMI Z-score one on it, but the one that is currently on the website is really only for adults. So it's really for individuals 19 years and above that you can actually use that. All right, so that's just some of the interventions that are possible, and that's the web link. So broadly speaking, what are the interventions again? Counseling, where we're going to give counseling, motivational interviewing, something that CCFP like to train individuals on. A referral to the member of the health team that can help us, whether it be a specialist, social worker, physiotherapist, dietitian, and of course treatment, which oftentimes is pharmacological. The dietary perspective part, there is the food-based dietary guidelines. On the website I just went on, there are some additional dietary hints. The broad thing that we wish to cover is that you need to eat more fruits and vegetables, you need to eat more beans, and you need to make physical activity a part of your daily routine. And it also provides you some tips for healthy eating, as well as to reduce the amount of fats and oil, which contributes to cardiovascular diseases. All right, so all of these resources are available. They are local resources. This is a resource by Pat Thompson, which is a caloric counter. The website also links you to a database that also can assist you in terms of counting calories, if you wish to do that. Here, this one might work a little better now. Right, right. So let's just bring this over here so you can see it. So this is the BMI calculator I was telling you about. It works primarily for adults 19 and above. And it also gives you some additional information as to how it is that you can actually eat healthy. All right. So in terms of nutritional tips through the life courses, in the infancy, we say breastfeeding is the best. Adults, we try and ensure that you eat your fruits and your vegetables daily. Someone mentioned what advice do you give for individuals trying to lose weight? Broadly speaking, you can either have low carbohydrate diets, you can have low fat diets. The better one seems to be the low carbohydrate diets, tend to be associated with greater weight loss than low fat. In the elderly, something that we need to be aware of is sarcopenia. You'll hear us talk about it quite a bit. This is where the muscles become weak. Even though you may have good structure, good BMI, the muscles are weak. It's a feature of aging. And the thing to improve your sarcopenia and so reduce the risk of fall and so on is to have a relatively good dietary protein intake and to ensure that individuals do with some weight training. Right? At the public health level, Julia and colleagues are working at other public health policies. So you'll see a lot of articles on food labeling, working with industry to promote healthy foods, school feeding programs. You may hear about the health and family life programs in school and communities, and various organizations, NGOs may be working with this. And of course, we need the appropriate laws to support breastfeeding. The current maternity law, you'll hear me with this, is insufficient. The 12 weeks can't cut in a dash because the World Health Organization recommends that mothers should breastfeed for 6 months. And so we really need to start looking at how it is that we're going to be supporting our breastfeeding mommies, and also look and see how we can be supporting for paternity leave for people like myself. Exercise is always important. Different forms of exercise. We all know what the benefits of exercise are. And the goal is to try to ensure that we get at least 30 minutes of exercise in an activity that is enjoyable and can fit within our daily routine. The Jamaica Moves campaign is not dead. We know we need physical environments to promote activities, so we need to look at some of the public spaces in terms of parks and so on. This just represents some studies that we have done with UTech and at UWI, looking at public parks and how they have been used for exercise activities. And the long and short is that it does help promote exercise in the community. So that's one of the public health activities that we can engage in. So in summary, I'm closing now, is at 3 o'clock. And I know people are hungry, need to go and cook. In terms of the health promotion aspect, we want to consume a balanced diet that provides the body with the necessary requirements. We need to strive to make physical activity part of our daily activity. And we need to ensure that we screen in every encounter that we have with our clients. Thank you, ladies and gentlemen. It was a pleasure.
Thank you very much, Professor Reid. That is really wonderful. And I think everybody thought it was an excellent presentation, and that you also engaged us in exercises that made it click for us. So my take-home message for that would be green is average risk and not green is high risk. That's what we're aiming for. And so we want to make sure that every encounter we have, that we can use it in such a way so that we can help persons understand if they're average risk or high risk, because each one of us as an individual, as a patient, as a family, whatever we are doing, plays a part in each other's lives. We have a duty for ourselves, our patients have a duty for themselves. Together we work as partners in healthcare. I think the Ministry of Health is on behalf of all of us. I congratulate the Ministry of Health for the phenomenal work that they have been doing. So Dr. Julia Rowe-Porter, convey our congratulations to your team. It was really it's really an excellent project, and I know it is ongoing. Also, I would like to thank Lynn. All of us interacted with Lynn or got an email from Lynn. She is our administrator. She's Dr. Lynn Hyatt Thompson. And Mr. Samuel Heron, our technical engineer. And once again, the Minister of Health, thanking represented by Dr. Julia Rowe-Porter. Thank you so much. Dr. Charlotte Badassi, who opened the meeting with a word of prayer. And we know that God is with us throughout everything we do. The presenters, Dr. Pauline Williams-Green, Dr. Rohan Wilkes, and Professor Marvin Reid, they did an excellent job, each one of them. They were so clear. And to you, the participants, this could never have happened without you. And because you are here, you're actually part of everything that's going on, and you in your own practice, and through your practice is going to make healthcare better for all of the citizens in our country. So I wish you safety and wellness, and continue being kind to yourself. You have a duty to yourself to be kind to you, take time out for you, and also continue being kind to others. Remember that the Lord sees and knows everything, and He is always present. So I bless all of you. Have a wonderful week. Thank you.
Thank you. And thank you so much, everyone. It was a wonderful meeting. Really came in and opened up our eyes to what screening and the importance of screening as we move forward. So there are some questions in the chat I see about the CEs or the CMEs, apologies. I will attach in the chat here, I'll send you a link. This is just a follow-up survey, not a post test, just a follow-up survey to ensure that your needs were met. For us to understand how you enjoyed this interactive session. You'll see that a lot of things were different, some pre-recorded, some live presentations, and a very interactive presentation by Prof. Marvin Reid, where your actual participation was recorded and he was able to show how he's seeing 200, 300, 400 of you participating. So really trying to step it up in this pandemic era of how we learn and how we communicate with each other. So please go ahead, click on the link in the chat. It will take you to our Google Forms page. Please just fill out the information on the Google Forms page. It will ask you as well about your email and your name that you'd like to see on this CME. So please go ahead and do that there. So again, for CMEs, you don't need to type in the chat. Just go ahead and follow the Google link that's there, fill out the information, and we thank you very much. Thanks again, Dr. Buckland. Thanks, everyone. Stay safe. Have a wonderful day. I'll leave this room open just a little bit for the chat, but have a great day.
One moment, Sam.
Yes.
I saw some questions in the area.
Sure. We could do that while we get persons to do the survey. Yeah, sure.
First question, what format does the Ministry of Health and Wellness recommend for students, school health and immunization visits? What format does the Ministry of Health recommend? All right. Some schools prefer to be responsible to ensure that all their students have their required annual school health and immunization clinic visits, as some parents may not have time off to take their children for the visits. Oh, what is this saying? All right, anybody would like to, Julia, would you like to respond to that?
Sure. So the Ministry of Education will speak to the frequency, but surely, for example, in the Child Health and Development Passport, every child entering early childhood institution at age 2 to 5, children entering primary school, and children entering high school must have an evaluation done for school medicals. In terms of the frequency, we know that annually to submit an annual school medical may be difficult, especially at this time. So the frequency is dependent on what the Ministry of Education recommends. Surely they should be on a clinic in terms of health. Every child should have an annual checkup. Where school medical frequency and submission of those is concerned, the Education Ministry and what is in the Child Health and Development Passport, which goes up to age 17, is really what is recommended for school-age children.
Right, thanks. What's the best treatment for a 71-year-old male whose systolic blood pressure is generally between 180 to 200 and the diastolic 80 to 100, mostly averaging 90?
That individual is very high risk and needs joint care between the primary care team and the specialist.
Yes, that's right. All right, there doesn't seem to be any green block in persons in the older age groups. Does this mean that age is an independent risk irrespective of other parameters?
In a sense, you could interpret it that way. The long and short of it is that, remember, what these are supposed to represent are 10-year risk. So clearly, it's unlikely that individual 70 is going to live because of life expectancy. Is going to live to 80 to 100. So the higher up you go, it's the more unlikely that you're going to find any green blocks in there.
And I just want to, in my mind, when we talk about 10-year risk, so it's going from 1 to 10. So the 10-year risk actually starts from the present moment.
That's correct, yes.
So we need to not just think about the future. We're actually living in the now and what we can do about, what we need to do about now. Make things better so that 10 years later, it's looking a lot better because we did something about our risk. Yes.
Sure. We did something sustainable. We don't just did it today and stop tomorrow.
That's right. What if total cholesterol is at 6, but the HDL is high? Does it change the risk assessment?
So again, people should not confuse a screening process with an assessment process. And I think part of what we went to go through today is really to say what we're trying to do is screening. In screening, what you're trying to do is to identify individuals who are at high risk. For that purposes of identifying, the total cholesterol works just as well because it's a practically more easily obtained than an HDL cholesterol. And so for the tools as we have them, we just need your total cholesterol. Now, when you are have what we call your full medical evaluation, which is the assessment, we will take additional bits of information. And so we would fractionate you, we'll look at your HDL, we'll look at other things, we'll look at your genetic components, based on your history, we'll look at what other things we find. And then at the end of the day, we will come up with a treatment that we think matches what the assessment tells us. So screening is really like triaging in an emergency scenario.
Yeah.
Hopefully we quickly identify individuals who are not well. Because remember, you're asymptomatic for screening. At the screening stage, you're asymptomatic. We want to identify you to say, hey, you may not recognize that things are not going so well, but this little test tells me something is wrong. Let us go and assess you fully.
Yeah.
All right?
Yeah, so you mentioned something important. You're looking at screening, which is different from assessment.
Yes.
Yeah, it's important. Okay. So the Framingham risk score is an assessment. It has so many things in it.
Yes. So the first thing first is that although we look at it that way, some tools are both screening and assessment tools.
Right.
Some
Right.
tools are both screening and assessment tools.
There's an overlap.
While some tools are purely for screening.
Right, I got you. That's a very good point. Do you think that in educational discussions of screening for cardiovascular disease and diabetes, that the 2 screening questions for depression screening should be integrated just like blood pressure and blood sugar?
The short answer is yes. The short answer is yes. As Julia was at pains to point out, it's an holistic approach. So screening, as we are practicing, as we propose to roll out, will involve screening for cancers, depression, and cardiovascular risk. That's how we're proposing to roll it out. So it's a holistic thing. But we couldn't, for the purposes of just the training exercises, we have broken it down into segments or modules. But in real life, in the real scenario, you would have a set of screening tools which will cover all of what we just mentioned.
Right. Why is it that the diagnosis of diabetes doesn't automatically place you in a higher risk group? In the past, we were advised that a diagnosis of diabetes correlates to having had a heart attack.
So again, we're conflating screening with assessment.
Right.
So a screening tool is supposed to be simple. You may be in a community doing a health fair where you don't have a blood sugar, but you can do a height and a weight. So the long and short of it is that once it is that you have identified an individual who's at a high risk, you then need to assess him. When you do the assessment, if that person is confirmed to be diabetic, the data says people with diabetes are much higher risk than anything else. So again, please don't conflate the screening and the assessment.
Right. Does AminoPep contribute toward preventing sarcopenia?
So what prevents sarcopenia is to ensure that you have a minimum amount of protein in your diet and that you do weight training. Those are the two key deliverables. How you get that minimum amount of protein is really up to you. What AminoPep does is that it just provides it with some substrate, which is an amino acid. So if you're deficient, it may contribute or may help in that regard.
Thank you. What interval do you use between rechecking the blood pressure times 2 when screening?
Well, typically most people would say between 5 to 10 minutes of rest.
Right. Where can we find the charts to screen for risk? It's on the website.
So the Ministry of Health is in the process of rolling out all of this to all health centers. They are also on the website because it's the World Health Organization charts that we use. And they're constructing their own website, which will list all of these as resources. So if you can't wait to get your own hand-printed, personalized, signed by Dr. Roporter or Dr. Skiles, you can download it like Dr. Buckland did, or you can go to the website.
You know, Prof. Marvin, they can't wait. You know why? Because they got to act now. I said the act now. No picture.
But you have connected us so far there on the deployment.
I Googled WHO cardiovascular disease risk charts. All right, just put in WHO cardiovascular disease risk charts, and it just comes up. And you just do what you need to do. Will this webinar be available for viewing later?
Yes.
Okay. And how does the Ministry of Health and Wellness gather and use data obtained from these numerous school medicals?
Oh, Julia.
You've been answering well on our behalf so far. But in terms of the data from the school medicals, we don't actively collect that data. However, there is what we're doing is we're rolling out what you call school health registers, which will actually document those that have chronic illnesses or risk factors for chronic illnesses. And data can be had from those registers. If we were going to analyze data from the school medicals, we would have to have an electronic system in place. There's so many moving parts. We're trying to move towards electronic health records. We're trying to move towards also, well, that's more in the medium term, but at this point in time, just to also answer some other queries before you continue with the other questions, we are developing tools that will help with screening and assessment for the patient, and we've developed a tool called Living Well. It's a guide to screening for the general population, those in a workplace or in a community. So the screening guidelines, we've broken it down into simple terms for children, adults, and elderly. We are developing tools for healthcare workers as well that you can look at the guidelines at a glance so that you'll have a desk reference to know, for the patient in front of you, a 40-year-old female, you know, what are her screening tests that are due right now today, and what frequency is she high risk or average risk for each of the priority conditions, that kind of thing. And we're really also trying to pilot a wellness clinic where we want to work through what the ideal patient-centered approach ought to be, and it's something we'd like to roll out eventually with time. So there's a lot in train. We are planning to upload this video and other training resources like the videos for the interim guidelines, Dr. Wilkes' video, and other resources as well are going to be on our NCD website, and you can look out for more information and resources through the CCFP to access these resources.
Thank you so much. Is there anything else that we need to do? Sam, you had wanted the participants to do something?
Right. So they've been doing it. Everyone's been filling out the post survey, 486 responses so far. And I think the question and answers was really valuable. So I think that's it.
All right, thank you. And just to let the participants know that we actually do go through your responses and try and modify and address the concerns that you may raise. So it's a very important and valuable bit of exercise.
All right.
Thank you very much. And I wish all of you a wonderful week. Stay safe. Make sure everybody's vaccinated. Whatever you do, you just follow all the protocols that you need to do. All right. Continue being kind to yourself. That's a duty to you. Be kind to other people. All right. God bless you all.